Hi, I'm Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and it's my pleasure to introduce Dr. Christine Alexander, the Chairwoman of the Department of Family Medicine at MetroHealth in Cleveland, Ohio. Dr. Alexander, take it away.
Thank you. So Larry and I go way back. I feel like Larry has always been a huge part of my life since I was an intern. So it is always exciting to do all things FMEC. So I'd like to introduce to you a couple people that have joined in. That for those of you who weren't here when we did some of the introductions and we started the One Good Thing, Dr. Rahul Shenoy, who is actually becoming a faculty member at Geisinger. He was a graduate of our program and chief resident, and he was very rooted in the homeless healthcare projects and led our Doc on the Street program for a while before graduating. So Rahul, I asked him to join in to give kind of that resident early attending sort of perspective. And then we have Nathaniel Wiles, who is a third-year resident, who's kind of taking up from Rahul and working with our Doc on the Street program, DOTS. And then Valentina Pecoraro also kind of shares the passion of caring for the homeless, and she's a second-year resident. Dr. Amber Whited will be joining in. She was leaving the office so she could scoot home and join in from home. So we'll expect to see her. She's the residency program director. So you should be able to see my screen, typo and all, homeless healthcare. And I'd like to tell you a little bit about it because a lot of our work in this space actually is an outgrowth of the FMEC meeting. So we hosted the meeting in Cleveland. The meeting usually moves around the Northeast region of the country. And we hosted it in Cleveland in 2012. And at that time, this isn't an actual picture from that meeting because I couldn't find it on my phone. But basically at that meeting, we had a plenary speaker, and she was from the Santa Barbara Street Medicine Program, Mimi Doohan. If you do a lot of work in homeless healthcare, you might know that name. She's a faculty member in Santa Barbara, and she has this really interesting practice that she takes care of all these incredibly wealthy actors and actresses and people from Hollywood that pay her top dollar to be a boutique doctor for them. And she uses that funding to take care of people on the street here in the US as well as globally. And her perspectives were so fascinating because she said basically they're the same population, because there's lots of issues around trust and finding access to healthcare and healthcare that meets your own individual needs and so forth. And that plenary speech was so powerful that it motivated our residents to want to start a street medicine program. And we had kind of dabbled in that space a little bit here or there, but really never had a formal program. And at the end of that conference, the residency director said, yeah, let's do it. If you can figure it out, I will support you. She came to the faculty. We said, yep, we will support the residents in doing this, and let's start partnering. So at first, we were literally just going out onto the street, under bridges. Security from our hospital system came with us. People donated food. We gave away food and clothing and all of that, and worked to get people into shelters. And knowing that you reduce their mortality by at least 50% just getting them into a shelter. So we did a lot of that work at first, and that was the Doc on the Street program. And then it morphed as we became partners with a local church, St. Malachi. And they said, you know, we have this homeless shelter, and so we would really love to provide some medical care. And so could you come, especially like on Friday nights, we have a soup kitchen, and that really attracts the most amount of people. And could you come and provide some basic medical care there? So we partnered with St. Malachi. Again, this was largely resident driven. The residents did the bulk of the work. The residency program director became the core faculty member supervising the project. And even though she got a promotion to an associate dean position, locally she remains as the core faculty member for this project. And then lots of other volunteer faculty that come to supervise the residents and the students. We have volunteer students from a lot of the local schools, and we actually built it into the curriculum for one of our other local schools, NeoMed, that's the Northeast Ohio Medical College or Medical University. And their clerkship students that rotate with us, we make this part of their required experience. So this is like pre-COVID to give you a sense of the sorts of things that we did: blood pressure checks, vitals, you know, really some very basic healthcare. And then St. Malachi came to us and said, hey, you know, we have a shower program where the homeless clients can come in and get a shower for free, wash their clothing, get new clothing, get shoes, socks, that sort of thing. Can we develop some medical care, you know, during the shower program? And we had some grant money and we said, yep, we can figure that out. And so it started off with a nurse practitioner and a physician kind of offsetting each other. Now is largely a physician. We realized that so many of these patients could have access to health care because they were eligible for Medicaid, but none of them knew how to sign up. And you have to have an address to sign up for health care. So St. Malachi said, well, they could use our address. So we were able to connect with our enrollment specialists who got the patients signed up for Medicaid, which then enabled these patients to access the healthcare system in more ways than just during this program, and to get things like meds and labs and all that sort of stuff. And at about the same time, our hospital started a PharmD residency, and the residents were very interested in being a part of this program. So they kind of helped manage the shower clinic while our residents manage the evening program of the Doc on the Street. And then COVID hit, right? So we were like firing in all cylinders, feeling really good about the work that we were doing. And COVID came along, and the governor shuts down on March 13th, shuts down the schools and businesses and recommends social distancing. And in response to this, St. Malachi realized that they couldn't continue to do the work that they were doing and protect their staff as well as the clients that they served. And so they shut down the program. Now, I guess I have to say a few words at this juncture that that St. Malachi, the Doc on the Street program, was a program that largely was run through the wintertime months. It started roughly in October, ran through the spring, but once the weather got really nice, a lot of the patients that were served by that program would actually just go out onto the streets and the campsites and under the bridges. And so they kind of just closed it down for the season and then would reopen. And so since we were kind of getting close to that spring weather and they couldn't guarantee what was required by the governor, is what kind of pushed them in that direction. And I don't know, Rahul, if you want to jump in at this point and say a little bit about, you know, about these programs up to that point, and then we can talk a little bit about how we pivoted in the COVID pandemic.
Yeah, absolutely. Thank you, Dr. Alexander. I look at my time with homeless healthcare at MetroHealth pre-COVID and post-COVID. You know, they say never let any crisis go to waste. And I think in our case, when COVID hit, we were at the tail end of the 2019 winter DOTS season. And until rather the 2019-2020 winter season. Until then, we were, like Dr. Alexander said, we just had winter clinics where we were going out to the church and sort of we were working in a silo. But when the pandemic hit, an opportunity arose because there was this large unmet health need of a large homeless population that after a long time was being given focus to by the government, because the government was looking at this population as a possible source of vector of spreading the pandemic. And so in order to control the spread, they opened up hotels, they opened up, they increased the capacity at a lot of places for housing some of these folks who didn't have a place to go to. Why was it an opportunity? It was an opportunity because it allowed us to reach a larger number of people than we had ever reached before the pandemic. As a medical student, I did not have a lot of experience working with the homeless population. A lot of my experiences came around after I joined residency, and I can say with this surety that in hindsight, working with the homeless population really opened a whole world of medicine to me. There was just so much I didn't know because my learning was limited to the four walls of university or medical school or structures within residency. Uh, but you become more of an upstreamist if you're familiar with the concept of upstream medicine, which is you look at medicine holistically and not just as treating a medical problem with drugs or treating or throwing a band-aid on a problem. An upstreamist is a physician who looks at the whole continuum of social determinants, access to health, housing, food, all of these things. And so when DOT started many years ago, and I was in a position to help out, I jumped on this opportunity because it's such a great opportunity to learn and also give back a little bit. So like I was saying, till 2020 winter, our activities were limited to a church. We would go to a church and sort of in the winter months help treat basic conditions, connect people to resources. And then after the pandemic, there was an explosion in how varied our activities were, from seeing maybe 40 patients or 50 patients a week. We were now seeing 50 patients a day. We were now in contact with a large population. And it's not just the clinical aspect of diagnosing a problem when you're talking to someone who's homeless at these shelters. It's also listening to them, hearing them out. And that important quality of trust is how do you foster trust with a community that has had historically a lot of disenfranchisement, if I can use that word, or there's been a lot of taboo and negative connotations associated with caring for the homeless. It's changing. I think it's slowly changing. The fact that we're having this presentation today where young med students are actually even interested in this is a sign that there is a lot of hope, that we're slowly starting to see a change in how physicians are looking at this aspect of medicine. So when the pandemic hit, if you look at the presentation in your slide, these are all the shelters that we opened little clinics at. So we were going out to these places, hearing them out, testing them for COVID, screening them for COVID, connecting them to other health resources. And very soon we found ourselves in the midst of a population that had a huge number of unmet health needs. So I think we're on to something here. We're on to the pandemic has offered us an opportunity to sort of pivot from going in with your sort of toe in the water and sort of just, once a week sort of situation, to really looking at health for the homeless in a more holistic manner, connecting stakeholders, whether it's the local government, whether it's non-governmental organizations, companies who want to make this a part of their corporate social responsibility. There's so much we can do. And I see med students, graduate residents, attendings as linchpins in that strategy.
Yeah, I think that really was the explosion that hit. And, we were like kind of congratulating ourselves because we did such a nice job with our Doc on the Street program and shower clinic. And then you realize there's so much more. And especially the one clinic that you see at the top of the slide, 2100 Lakeside. I didn't know this, but that's the third largest shelter in the country. There's one in New York that's bigger. There's one in LA that's bigger, and then that one. So it really has been a fascinating process, becoming affiliated with them and figuring out ways to help maintain the health. And I think one of the things we're most proud of is that through our work with kind of strategizing with the county government and other stakeholders, we've been able to maintain the COVID positive rate at less than 3%, which is lower than the national average. So it's been really successful, really proud of that. I do want to leave a lot of time for your questions. I don't know if our other two residents, Valentina or Nathaniel, have anything that they would like to add to what Rahul has already shared, and then we'll open it up for questions. And Nathaniel, you are on mute.
Yeah, thanks,
There you
Dr. Alexander.
Welcome.
I have a few things. Some of it's piggybacking off of what Rahul said. I think one of the best things about the program is developing a trust with people who feel very marginalized, and also like developing a sense of their trust in medicine. Like sometimes we're just treating sore throats, but sometimes somebody comes into the clinic, they don't think it's a big deal, but actually they have hypertensive emergency and they need to get to the ED, but they don't really know because there's not that level of health literacy and education, and we can be there connecting them. But also not like, we have that in like individual cases, but also on the whole, we let people know that there's a space for them. And yeah, and that's not something that everybody who is experiencing homelessness gets on the day-to-day. The sense that somebody is there for them and that they have a place at the table, as it were. And then we've got loads of residents around that have clinics and need patients, and we have their business cards. So we can get people set up with a primary doc when they screen positive, or when you give them their pneumonia vaccination and you find out they haven't had any others at all. So yeah, it's kind of a jump off point.
Agreed. Val, do you have things you would like to add to that?
Yeah, so when I interviewed at the program, I actually interviewed with Jamil, who was the chief resident before Raul. And so one of the things that sold me on the program was DOTS. And when I became involved, I ended up going almost every single Friday. And going back to the holistic approach, we do healthcare there, but we also had a lot of donations for things like hats, gloves, socks, coats, things that really helped homeless people stay warm, and another aspect of the preventative medicine. And as Nate was saying, with hypertensive emergency, we're able to give them some care that way. And we also have breathing treatments. And then through the donations, we have been able to vaccinate a significant part of the homeless population just there on a Friday night, where usually, they might come into the hospital, they might not be offered a vaccine, or they might be too scared. But when you see them in their own home, in their own setting, they're more appreciative and willing to get the vaccines, like pneumonia vaccine, flu vaccine. And then also piggybacking on Raul with like the tip of the iceberg. So this used to just be a 2-hour event, 3-hour event on Fridays. And then they made it every single day for a couple months. And I think it wasn't just 50, Raul, you guys were seeing 100 patients a day, which was really, really nice. And I think they were really innovative with taking this program that was only 3 hours a day, 3 hours once a week, to 5 days a week, 100 plus patients a day. And then also being very innovative with putting people in high-risk hotels, low-risk hotels, and again, branching that healthcare during the pandemic. So I'm excited to see where DOTS will go. That's
the limit.
So
I do just want to take a quick second to recognize that Dr. Amber Whited-Watson, our residency director, has logged on. So I just wanted to give a quick shout out to her, that she's with us. And I think we can open it up to questions, which might be that if you feel like you want to unmute and send a question or a comment or a thought, please feel free to do that. If you want to use the chat space, I'll keep an eye on the chat, so if you have a question about that. But I have to say, like, I agree with what Valentina has shared, that, and Nathaniel too, that we started off at this really small program, and then because of the needs of the pandemic, it really exploded, and the residents were unbelievable. Because we literally went from, oh my gosh, what are we going to do? Like our sweet space, our sweet clinic is getting closed early, and there's this pandemic, and I think we were all worried and scared. about that. And literally by the next morning, my boss, who's the chief, oh, here we go. We have another person.
The link is not opening, so
Okay.
I'm like,
Yep.
here.
So we have Dr. Tessa Rothi, who just joined. She is one of the other faculty that supervises the Doc on the Street program, and she's actually here also because she has a patient in labor. So many reasons for her to be here tonight. And so what I was saying was that we went from this kind of manageable size experience to the chief medical officer of the organization reaching out to me to say, what are you going to do to manage the homeless? And I said, well, our clinic is closed. And he responded back, yeah, so what are you going to do to manage the homeless? And in that moment, I got it. Like, he means, what are we doing to manage the entire homeless population of Cleveland? That's what he was asking me. And so we reached out to the county office for homelessness, and that's kind of how it got started rolling. And the residents just jumped in, like, with both feet every day, sending 2 and 3 people out to a whole network of shelters and our school health program, which is something you can log in and hear about on Wednesday. But our leader of our school health program, our program director, Katie Davis, was just instrumental in jumping in because the schools were closed down and there was little we could do for the schools at that point. And so she jumped onto this project, and the residents jumped in. And another faculty member who is celebrating Yom Kippur tonight, he wasn't able to be with us. Michael Seidman has also been, one of the backbones of how we manage the homeless. So I will stop there. I don't see a message in the chat room, but feel free to just remember you have to unmute yourself.
Hello again, this is Daniel. I just had a question. How big is your homeless population in Cleveland?
So that is such an excellent question, and we really grappled to get some good figures on that. The hard part about it is, just like anything, that this population isn't really easily visible. So I have heard estimates from anywhere from 10,000 to 40,000. I've also heard as little as 200. It really depends on the data set that you look at. And because also the population, like for instance, at 2100 Lakeside, they check in on a daily basis. I mean, that's typically how it works with most. So that check in on a daily basis, sometimes those are repeat people and sometimes those are new people. And then I think the other piece of it is that there were people who became temporarily homeless because of COVID, that they were in the hospital and maybe they lived with someone who was super high risk, that maybe was getting chemotherapy or immune suppressed or chronic steroids. So they became temporarily homeless and couldn't go home. So we kind of had to figure out ways to help manage them as well. So I wish I had a much better answer. The data is all over the place. I would say it's safe to say thousands.
Wow, thank you.
And I think that became really obvious when we had such a small population on the Friday nights, and then how we were filling up hotels. I don't think I realized how many homeless people there were until we were filling up the hotels and testing people for COVID, really how many homeless people there are. I do think there was a question in the chat though. I don't know if you were able to see it.
I'm glad, thank you, Val. So it says, how does this initiative fit into the curriculum, or is this all volunteering by the residents and faculty? So Dr. White, do you want to talk a little bit about how it fits into the curriculum?
Sure, I can do that. So it is on a volunteer basis. All of our residents give their evenings and extra time up. During the pandemic, it was still voluntary, but a lot of residents volunteered to, when they were displaced from a surgery rotation or whatever rotation they were on, they would volunteer to do the work in the shelters. But yeah, former resident Rahul really was instrumental in keeping the DOTS program running, and that was also on a volunteer basis as well.
And definitely for the faculty, they volunteer to supervise the students and residents. You know, so it was, I guess, if you think about like what happened in COVID, it was, you know, during the day, it wasn't just in the evenings. So it was all day, you know, like 8 to 5, all day, every day. But we didn't force anybody to go, because if you felt like you were at risk for the exposure, you know, we didn't want anybody to feel forced. We did have a pretty generous amount of protective gear, so that, but we didn't want to, you know, make anybody go who felt unsafe in any way. So in that way, it was volunteer, but it was during the day. And then I see another question. Are there any potential areas of improvement that you can see future residents helping to target and or helping to destigmatize? In other words, what do you see for the future of the program? And I don't know if either of the residents, any of the residents want to speak to this, but I'm going to take a crack at it first, and then you can correct me. So a piece of what I've done, you know, if we're going to have this as a regular rotational experience, it kind of has to fit into the curriculum. And curriculum for family medicine is a pretty full curriculum, so you have to kind of figure out where that carve out is. And so that's kind of like a curricular educational learning piece. For the faculty, if we send them, I have to figure out how to fund the faculty to do that. You know, do they do it during their teaching time or their administrative time? Or is it part of their clinical time? And if they're not generating a bill for services provided, I have to have a source of funding to pay them to do that. And so a lot of that happens through grant funding and endowments. And so we're constantly looking at that. We're on track for a potential donor to more heavily fund this program. But after having been in a couple of these shelters, some of the agencies that also help to do work and support the shelters are asking to fund us and to, at the very least, do telehealth along with some in-person. So we're working on some partnerships. So I think the future of this program is going to grow. I just think the pandemic has turned everything on its head. And so I think when that happens, as Rahul said, no crisis should go wasted. Like, we should learn something from every crisis, and we should make the world a better place as a result. So that's kind of where I think we're going. I don't know if others have anything to add to that.
I think sort of piggybacking on what Dr. Alexander was saying, once the program is sort of figured out how this will fit into the curriculum, I think from a resident and a student standpoint, the future is going to be we becoming more integrated into the Cleveland homeless system as a residency program. We're already in the door because of what happened these past 7 months. And just as I was graduating residency, I got a sense the shelters were so appreciative of what we were doing, that our residents were going in and taking time out and helping them. Our attendings were doing the same. And I don't think they had that in-depth contact with faculty and residents until then. And so the pandemic, in strange ways, has broken walls that existed in the past between Cleveland's public health hospital, which is our hospital, MetroHealth, and the Cleveland public homeless shelter system. The pandemic has broken that wall. So the future, I think, is going to be maybe possibly clinics or more regular full spectrum family medicine care in the shelters. The other thing that came up from the pandemic was the women's shelters have almost no women health services. So that could be another possibility. So I see those silos breaking up because of what the pandemic has done. And that's a good thing.
Yeah. Yeah, and I think it really did destigmatize for the residents who had never worked with the homeless population, or faculty who had not worked with the homeless population. I think it really did remove so much stigma to be out with the homeless patients and to realize that these are just our patients in a different location. Like, these are our people. These are the people we see in the office. you know, these are the people that we take care of. They're the people we run into at the grocery store. There's the people, you know, like they are our people. And we're just kind of seeing them in a slightly different place.
Setting,
yeah, different setting.
Yeah, I would echo that same thing. I think
I'm going to move this closer. So
yeah, these are the, you know, one of our aim and mission of our program is to serve for the vulnerable population. You know, they were coming to our clinic, you know, because of the pandemic, you know, we were going to their place and seeing them. That's the difference. Pretty much all of the, you know, the patients that we see in our clinic, we see them in the docks, and also we see them in the homeless shelter.
So we have another really good question here. I'm curious about the follow-up. How do you help patients afford or obtain meds, stay on them, and follow up with specialist appointments? So that really can be a challenge, and I feel like we started to crack that nut a little bit. That our revenue integrity group, so that's the group that does like all the coding and billing and all that sort of stuff. They have a group that are trained specialists to help folks get signed up for Medicaid. And living in Ohio, we had a huge expansion of Medicaid offerings to our patients. So we take advantage of that. So the revenue specialists actually get the patient signed up. So when the patient comes to the shelter and they get registered at the shelter, there's a communication between that registrant at the shelter and our system so that they get an electronic medical record and they get an assessment about whether or not they had Medicaid and get it either renewed or signed up for the first time. And we utilize the shelter's address for their address. So that's the way of getting them kind of an entry point that then allows them to get medications. And so what we would do is when we would see the patients that needed meds, we called them into our Metro pharmacy. Our Metro pharmacy has this special pricing called 340B, which makes medicines available as cheap as is humanly possible. And because they now had Medicaid coverage, they basically get the medicines for free. And then our pharmacy has a delivery service. So we can deliver the meds. And often that was really just us picking up the meds and taking them with us when we went to the shelters or when we had dispersed people to hotels. I think Val had alluded to, we had the sick hotels, so people who had symptoms or had been likely, having COVID, they were at one hotel. We had another hotel for people who had risk factors but didn't have symptoms. We had another hotel for people who were diagnosed positive with COVID, so that we kind of kept them separate. But we could get the meds there when we would go there if those people needed to be seen face to face, or if we were going there to do more testing, we delivered the meds. So there were lots of different ways to get the meds to them. To maintain the specialist appointments, certainly telehealth was made a lot easier by the fact that they were either in the shelter where we could do a telehealth appointment with them and the shelter staff facilitated that, or they were at the hotels where they now had access to a phone. And then the agencies that helped cover the hotels could help to mediate that. And those patients all got put on the residence schedules for telehealth. So, and then we could connect to specialists. If they needed a specialist, we'd put the referral in. Katie would make sure they had an appointment. They got the specialist appointment. Outside of COVID, it is a little trickier because, they are such a transient population. And so we've worked really hard to make sure everybody has the Medicaid and that we have some way to contact them about the appointments. And mainly that meant that when they were at the shower clinic, we would call and get the appointment right then and there. The Doc on the Street program happens after hours, so that becomes a little bit more challenging to get it. Again, with telehealth, I think that does make a big difference. So, sorry, I'm having a little technical difficulty. My battery just went down. So, okay, I think can y'all still hear me?
Yep, still
Yes.
hear
Yes.
you. I think we can't see you, but we can still hear you, Dr. Alexander.
So there's a question about compliance for follow-up appointments. What do you guys think from the patients that you saw, for the residents on the call, what do you think about that piece of it? Because they would get put on the schedule and then you guys would be the ones doing appointments. And then I'll add in what I was thinking.
Yeah, of course. So before the pandemic, our follow-up rates were not as good as the follow-up rates that you would expect in a population that came to clinic, for obvious reasons. A lot of this population have temporal relationships with places. They're moving between different neighborhoods. They're moving to wherever the food is available that particular day. To summarize it, our follow-up rates were probably 25% of what they would be in clinic. But here's the good thing. We never worked directly with the folks, in the sense there was always a liaison who was working with us, a community worker who knows everyone in the shelter, who we could always reach out to if we needed to follow up with someone. So for instance, if someone needed antibiotics, I'm giving you an example, and we treated an infection, but we also wanted to follow up in a week. We would make sure that the community worker knows that this person needs to be seen in a week. And so we sort of had that working relationship with the community worker who was liaisoning between us and the population, because they know where people are moving every day based on where the soup kitchens are open, where shelter is available that particular night. With regards to the question about specialist appointments, I had a patient who had really bad bipolar disorder, and she was having a decompensating episode at the shelter, and she needed to be taken to the hospital. And so we got an ambulance to take her to the hospital. The next week, I found her back at the shelter, and she was a completely different person. She was started on her medications, and so what we did was we connected her to the public health, the public transportation system that Metro has, which are basically free buses that pick you up from certain locations, so that she could make it to her specialist appointments. And so that's one of the things we do to ensure there's compliance and follow-ups. Is it 100% effective? No. Like I said, it's probably 25% as good as it would be in a regular template. But that's one of the challenges of homeless medicine is you're not going to have the same rates of follow-up as you would in a clinic. Nate, do you have something from your experiences?
Yeah, but also some of these patients, they have a primary care provider and Care Alliance, from our docs. So they may prefer to go back to Care Alliance and see their primary care provider. And that's totally fine. I think that's better continuity of care, if they are seeing in Care Alliance.
So Dr. Desarathi is referencing Care Alliance, which is one of the local federally qualified health centers, and their whole charge is to take care of homeless patients. So that's what they were established to do and have federal funding to do. So if patients are already connected to Care Alliance, we try to be respectful of that connection and to get them, connected back to Care Alliance. But if they aren't, which, certainly this is a very transient population. So you really do, as Rahul suggests, you really do have to view them through a different lens. You can't do the, we want to see you back in 4 weeks, sort of thing. You have to kind of readjust your thinking to say, when can you next be here? When can I connect with you again? Or, I'm concerned about you, I'm worried about you, I would like to see you. So, and we do provide transportation to get people to the hospital. And I think the homeless population, sometimes people think that they aren't resourceful. They're some of the most resilient, resourceful people you will ever meet. And I think it's so easy to judge and to think that they're not skilled. They're skilled. If you have to figure out how to survive every day on the streets, right? You've got some real skill. And so sometimes I think we all think we have to do everything for them. And you don't necessarily, you just have to let them know, hey, do you know about these resources that are available to you? Because they may or may not know. But yeah, we really try. It really is the human connection that I think they need. And once that human connection is made, then I think they will find their way back, and they will, they will try to be as compliant as possible. If you don't have a phone, it's hard to call for your refills. So, and if your choice is, I can go out and find food today, or I can figure out a way to get my script, you're gonna get food, or even simple things like, well, you have heart failure, you should be on a salt-free diet. Well, you're eating in a soup kitchen. Chances are the food is already salted, So there are those sorts of things that we have to ourselves readjust our thinking to see the world through their lens.
Nate or Val or Rahul, would you answer the other question that was on the chat that I think we missed, or what are the common diagnoses or health problems that you see? And is there anything in particular you'd like to cover at each visit?
I think Raul could probably correct me on this, or Dr. Alexander. I think that one of the reasons that we started JOTS was there was a person who was seen on the street with frostbite who wasn't allowed into a shelter due to a skin condition. And so in the shelters that we do go to, they don't exclude people by skin condition. So you will see people with wind rash, head lice, eczema that's left untreated, scabies. So skin conditions in that population is pretty common, especially in the winter time, as well as some fungal infections. And then at every single Friday, we have multiple blood pressure cuffs to screen people for their blood pressures, as well as AccuChecks to see what their blood sugar is at that moment. And then of course, everybody has a stethoscope to listen to heart and lungs. So those are things that pretty much every single person who shows up on Friday always gets a blood pressure, an AccuCheck, and somebody listening to their heart and lungs. And then we do have portable otoscopes that we can use to look inside their ears to see if they have any ear infections, since of course it is the winter time and they are susceptible to colds and ear infections. So those are probably the biggest things that we screen for, is diabetes and high blood pressure. And then a lot of them might have COPD or asthma. So listening to their lungs is pretty important in that population in the winter time. So that's why we give the pneumonia and flu vaccines out. And then I would say probably the most common thing we see besides a common cold, I would say, is the skin conditions, at least in my personal experience. I don't know if anyone else wants to have some input on that.
Rahul, or is that?
Yeah, I think the only other thing I would add is a lot of mental health and substance use disorders. That's the only thing I would add to what Val was saying. Also, a lot of gender dysphoria, patients who have been, or folks who have become homeless because of stigma within their families about sexual orientation, substance use, and all of those things.
Yeah, I think I would agree with that. I think sometimes people just want to be listened to, that they may have a skin condition, they may have, a few things like that, but they're starved to really be listened to. And so, I think that that's such a huge piece. And I think especially for the students, that's always so eye-opening, because I think, harkening back to when I was a student, I felt like I didn't know enough to really truly be helpful to someone. I couldn't exactly diagnose their heart failure. I wasn't sure if there was an S3 or an S4. I didn't, I just didn't have as many skills, but the skill I did have was to listen. And so I felt like that's the biggest thing that I had to offer as an early year student. And I think that that is so meaningful for the students that we see, is that they are that listening ear, and they are that person who can really start to develop trust for that homeless patient, to feel like it's okay and it's safe and that they have value, and that we're here for them. So I think just, really the depression, anxiety, just having a willing ear is huge.
Oh, sorry.
Warning.
Yeah, I would echo that. This is basically developing a trust in the healthcare system, as such. So, by talking to the students, by talking to the residents, they develop a trust in the healthcare system, and they seek care for their illness. That's primarily our goal, so that we can develop the connection with those patients.
Maybe we can leave a space real quick. I saw somebody unmute to ask a question.
That was me.
There we go, Alexandra. I just saw that too. Thank you.
That's okay. Yeah, so I just had a quick question. Dr. Alexander, earlier you mentioned like the finding a connection with these patients in order to develop, trust. And it just got me thinking, this is maybe more for the residents or who do the DOTS program. But do you have like a favorite or memorable connection with a patient, or maybe an interaction with one of these patients?
So
I
was just gonna say I have one, but I think Javidia has a really good one. Can you guys hear her okay? Yeah, okay.
I think one of the that we did in DOTS program is we wrote a grant, and then we got a grant, and we got a support to buy some supplies, like over-the-counter supplies and socks and some over-the-counter medications. So basically, showing a gesture of we care about you. Here you go. We don't want you to be in the cold without socks. And then sometime I brought even underwear for them, bags for them. Some of the things that I found at my home that I don't use it, I just take it, with me and then give it to them. That really helps to develop that relationship. The second thing is about the trust. One of my memory is, I was seeing a patient, who had a schizophrenia. So he was kind of, every time he comes to the DOTS, just to say hello to me, and he writes a poem. So, every time, he would write a poem, everyone told him that he was crazy. That was his impression. So when he came to me and he showed the poem, and, I tried to read the poem, and I was just kind of looking at it. Okay, what's the meaning of it? I spend some time every time. So he writes me poem every time when I come in. So that was one of the best moments that I felt that, he write a poem, keep it ready. And then every time when I go in and ask him, what's the poem for today? And then, here you go, he just put a heart and then wrote something inside and then show me that poem. I was kind of looking at it, and I asked him, explain the meaning to me. I don't, I am not as good as you to write a poem, or I'm not as good as you to understand it either. So he explains to me all those things, that kind of give him some reward that what he is skilled in. So that kind of developed a connection, with the patient. That I think one of the moments that I really, cherish that moment.
Rahul, Val, Nate, do you have a patient that stood out for you?
Yeah, I have many, and I'm living in Cleveland. I'm still living in Cleveland, and it's been 3 months since I graduated. And when I go grocery shopping, and I sometimes run into people I know, I'm like, I know you from somewhere, and they're like, yeah, we know each other from DOTS. So I have friends, I guess, all over the city now. The patients that really sort of stay in my mind, it's more that feeling that. When you're burnt out as a physician, or sometimes residency can sort of lead you to get burnt out with regular routine, and homeless medicine takes me out of the four walls of the hospital and allows me to practice medicine in a little different way, and it sort of makes my week a little more interesting each time I would do that, because I would step out from regimented structural electronic health record directed medicine to just talking to someone. And it was just so refreshing from a well-being standpoint. Was just speaking to these patients. It was like, oh, this is how medicine should be. Just talking to the patient, you're doing your physical exam, and you're connecting the patient to resources. There was this one patient I distinctly remember. She was probably in her 60s, and she, I guess, stolen like one of those shopping carts from Walmart, and that was her house. She'd have all her stuff in that shopping cart, and she had found a way to sort of carry her cat with the shopping cart. And she was like, the city is killing all the cats. This was 2019, I think. I'm like, what do you mean the city is killing the cats? She's like, no, they're killing all the cats. And I'm worried because she had her own cat. And the next thing I know, news can be very untrustworthy these days. As you need to look at your sources. But the next thing I look, and it was true. She was never lying. There was a cat. I don't know what they call it, but basically putting down stray cats. And she was absolutely right about, so I was getting my news from her. So it's really interesting about getting perspectives about things you don't hear about. And it's important to them. It's important to for them to speak to someone about these things. And yeah, like I said, it's basically you have a different way of looking at medicine. And two, because they trust you with their innermost fears, they don't have anyone else to share it with. They tell you things about the city, and you really understand about the community that you're living in outside of structure.
I know we just have a few minutes. I don't know if Val or Nathaniel has somebody that they want to share the story of.
Yeah, sure. There were two that popped to mind. The one I alluded to before, it was the one lady that was having chest pain that came in. And I think she had used cocaine earlier in the day. And maybe it was that she had, with relative frequency, experienced chest pain after using cocaine, but she wasn't entirely convinced that it was that big of a deal. And then her blood pressure was like sky high. So I don't know, we kind of had a long conversation of developing trust, convincing her that going to the ED was a good idea. So that was great. And I think the same night, there was a guy who'd gotten into a fight and had a pretty big black on his hand. And he was confused why they hadn't like sewn it up real tight. And so we had a conversation about wound healing and infection, and that was great. Yeah, because I love educating patients, and being able to have somebody who's asking questions and interested in their health is really refreshing. So that was a good experience for me.
What do you think?
Somebody else unmute earlier. I didn't know if we wanted to just in the last 3 minutes ask if somebody else had a question.
I guess I had a question. I was curious because it's come up a couple times, so I was wondering, how do you guys deal with this? Not so that harsh. How do you work with your patients in substance abuse? I know I personally worked with a woman who was homeless earlier today, and I just felt so blocked in terms of like, I didn't know how to approach the subject or talk to her, or if it even made sense in the context.
Mm-hmm. So it's really interesting because the person that I thought of was the person I saw at DOTS who was celebrating 1 week of sobriety, and like how proud he was of being sober for a week. And so there are lots of agencies with whom we are connected because we are the safety net hospital. And so there are opportunities to get people connected for care if that's what they choose. And, just like everything else, it's like, the stages of behavioral change that some people are still actively using and others are ready. And if they're ready to make the change that they want to choose sobriety, we do have ways to get them connected. If it is opiate use, nearly all of the faculty are ex-waivered. So we have opportunities to get them connected with a medication-assisted therapy program right within our own department. And some of the residents actually are undergoing the training to have their own independent ex-waivers as well. We have that training coming up. So there'll be opportunities. It's a growing field, but we have lots of ways we can get them connected to agencies and to care.
Dr. Alexander, this is Larry. I'm going to bring things to closure. We're running out of time. This has been an awesome conversation and a real privilege to listen in. Thank you very much for you and your team.
Thank you so much. Really appreciate your time tonight.
If there's any students here who want a scholarship to our meeting this weekend, please go to our website and sign up if you already haven't. We're keeping the doors open.
Yep, and if you've signed up, please feel free to come and see us at our booth, in the MetroHealth system. So We'll talk to you later. Have a great night. Thanks, everybody.